Medicos. Good day to all of you. This is Dr. BK for you, and today I am here to discuss about one more topic on the abdomen region, that is the posterior abdominal wall. Followed by that, I will be discussing in detail about the diaphragm, that is the thoracoabdominal diaphragm. Now, our learning objectives will be for today, the first part of the lecture covering the posterior abdominal wall. In that I will be mainly covering about the two muscles of the posterior abdominal wall. Followed by that, the facial disposition, the fascia of the posterior abdominal wall, and a brief account of the lumbar plexus. Next part of the lecture, on the second part of the lecture, I will be discussing about the diaphragm, mainly the attachments, the origin and insertion of the diaphragm, then the major openings which transmits these structures through these openings, then the minor openings of the diaphragm, the principal actions of the diaphragm, followed by a brief account of the development of the diaphragm, and finally I will conclude this chapter with the clinical aspects or the applied anatomy. Now, first to start with the posterior abdominal wall, it is mainly made up of skeletal components, muscular components, and also the facial components. So the muscles, if there definitely muscles are there, it will be lined by a fascia. The skeletal components are mainly formed by the 5 lumbar vertebrae. First lumbar, L1, L2, L3, L4 and L5 lumbar vertebrae. They mainly form the posterior and the midline. Laterally or superolaterally, the wall is actually supplemented by the ribs, the inner surface of the lower 3 or 4 ribs, and mostly it is the 11th and the 12th rib. Then below you have on either side the midline, the sacrum, and then the ala part of the sacrum, mainly the ala of the sacrum, and the iliac fossa. So mainly the iliac bone, the ala of the sacrum laterally. Midline, what you have is the 5 lumbar vertebrae, and above and laterally you have the 11th and the 12th rib. So this is the skeletal components. Muscular components, 2 muscles, mainly you see medially, immediately on either side of the vertebral column you see the psoas major and the minor muscle also. Lateral to the psoas major you see the quadratus lumborum muscle, and more laterally the transversus abdominis. Okay, so psoas major, quadratus lumborum, and then you have the what you have is the transversus abdominis muscle. Now, in the beginning introductory class of the abdomen, mainly we have started or I have discussed about the anterior abdominal wall. The anterior abdominal wall is also made up of muscles. Then you have the fascia. So mostly it made up of muscles and the fascia. Upper part you have the costal margin. Starting from the 9th rib to some extent you have the costal margin. The anterior abdominal wall is actually distensible. It is elastic, stretched, and it can distend or it can expand. It is actually adopted or modified in such a way so that it allows a distension of the wall, resilient, and at the same time it is flexible and elastic. Whereas posterior abdominal wall is not distensible, it cannot be expanded, and unlike the anterior abdominal wall which you can see on the surface, posterior abdominal wall is present at a deeper plane. because then more posteriorly you have the erector spinae group of muscles, and then you have the superficial muscles of the back. So at the back region, what you see, those muscles are the superficial muscles of the back. Mainly one large muscle, you see the latissimus dorsi. Then you have the erector spinae group of muscles, and only deep to that you see the posterior abdominal wall. The posterior abdominal wall is mainly supportive in nature. It supports the retroperitoneal organs, okay, like your duodenum, pancreas, and of course you have the kidneys on the posterior abdominal wall. And on the posterior abdominal wall you see the major vessels, the inferior vena cava and the abdominal aorta, their branches. Then you also come across the nerve plexuses, iliac plexus, aortic plexus, hypogastric plexus, and lymph nodes of the posterior abdominal wall. So mainly the great vessels and the nerves are all present on the posterior abdominal wall. Now coming to the muscles of the posterior abdominal wall, two muscles, as I told you, medially what you see is the psoas major muscle. It arises from the anterior surface of body of all 5 lumbar vertebrae and their adjoining intervertebral discs. Okay, and the adjoining intervertebral discs, it arises from the bodies of the anterior surface of the lumbar vertebrae and also the intervertebral discs. Not only that, it also takes origin from the tendinous arch. You are able to see 4 arches. This is actually formed by the thickening of the fascia, that is the psoas fascia. So this arches is because in between the arch you see the gaps which is going to transmit the lumbar arteries from the abdominal aorta. What happens? It transmits the lumbar arteries. It supplies the posterior abdominal wall structures. So from the transverse tendinous arches and from the bodies of the lumbar vertebra, the muscle passes downwards and converts into a tendon. It joins the tendon of iliacus muscle and forms a common iliopsoas tendon getting inserted into the lesser trochanter of the femur. It is the chief flexor of hip joint. The iliopsoas muscle, mainly it is the chief flexor of the thigh or the hip joint when acting from above. Above the muscle contracts, it flexes your hip. When acting from below, it is mainly responsible for flexion of the trunk. When acting from below, it actually responsible for the flexion of the trunk, bending ventrally. Nerve supply is actually from the 12th thoracic to all 5 lumbar nerves. That is the nerve supply of the psoas major muscle. The psoas major is covered by the psoas fascia and iliacus muscle is actually covered by the iliac fascia. So some books refer it as iliopsoas fascia also. So this fascia passes deep to the inguinal ligament as the posterior wall of the femoral. Mainly it forms the upper 4 centimeters of the femoral vessels, covering the upper 4 centimeters of the femoral vessels, that is the femoral sheath. So the posterior wall of the femoral sheath is actually formed by the posterior wall of the femoral sheath is actually formed by the psoas fascia or the iliopsoas fascia. Now, the iliopsoas fascia above the iliac crest, this fascia is called as purely psoas fascia. It thickens to form the medial, not the median, medial arcuate ligament. The upper part of the psoas fascia thickens to form the medial arcuate ligament. Then it forms tendinous arches in between the bodies of the lumbar vertebrae and between the gaps of the tendinous arches, it transmits the lumbar vessels. The medial arcuate ligament from the L1 vertebra go to the transverse body of L1 to the transverse process of L1 is the medial arcuate ligament. Then the psoas fascia laterally it is continuous with one more fascia covering the quadratus lumborum, that is the anterior layer of thoracolumbar fascia. Okay. So laterally it is continuous with the thoracolumbar fascia, blends with the thoracolumbar fascia. Psoas fascia, that is actually called as the psoas fascia. This psoas fascia is actually pierced by certain vessels and nerves because the certain nerves which are actually emerging out of the lumbar nerves, lumbar spinal nerves, they immediately form a plexus within the substance of the psoas major, and from that branches they arise, they pierce the muscle, in turn they pierce the fascia covering the muscle. So the psoas fascia is actually pierced by iliohypogastric, ilioinguinal, genitofemoral nerve, and more medially obturator nerve, iliolumbar arteries. Okay. So genitofemoral nerve, iliohypogastric, ilioinguinal, they are all branches of the lumbar plexus, and more medially I told you the obturator nerve, and then it is pierced by the fourth lumbar artery. Fourth lumbar artery is actually the branches which are given from the posterior side of the abdominal aorta. Lumbar arteries gives 4 lumbar arteries. Then lumbosacral trunk is again a combination of L4 and L5. Lumbosacral trunk. All these they actually pierce the psoas fascia and then they take their respective course to supply their structures. So as I told you, the iliolumbar artery and then more medially it will be pierced by the obturator nerve. These are the structures piercing the psoas fascia. Now one important clinical aspect of this psoas muscle and fascia is the psoas abscess. So collection of fluid deep to the psoas fascia is actually called as psoas abscess. You are able to see a large collection of abscess. This is actually called as the psoas abscess. This is actually your kidneys, lumbar vertebra, spinal cord inside the lumbar vertebra. This is your great vessels of the abdomen. This you are able to see the lumbar vertebra with the intervertebral discs. Now, this psoas abscess might occur due to cold abscess arising from the vertebra. So, cold abscess means tuberculosis mainly. The tuberculosis might form pus which might actually drag down to the psoas fascia, deep to the fascia between the muscle and the fascia. And the pus might drag down and point anywhere along the following locations. One in the femoral triangle, in the knee following the obturator nerve, knee or the adductor region, it might drag along with the obturator nerve. Through the genitofemoral nerve, it may track and go to the inguinal region. And I told you femoral nerve through that femoral triangle. It might also via the sciatic nerve might actually go to the gluteal region. Okay. So that is the importance of the psoas abscess. So the pus might point anywhere in the adductor region, knee, femoral triangle, inguinal region, or in the gluteal region. Based on the nerves which are emerging from them, it might follow the course of one of these structures and might point on the surface anywhere. So that is about the psoas abscess, which is mainly due to the cold abscess from the lumbar vertebra. The next muscle which we are going to discuss is the quadratus lumborum muscle. It's a quadrilateral muscle, so that is why it is called as quadratus lumborum. Fills the gap between the 12th rib and the hip bone, that is your iliac crest. So the posterior abdominal wall, the gap between the two skeletal components, 12th rib and the iliac crest, is filled by the quadratus lumborum muscle present lateral to the psoas major muscle, arises below from the ventral segment of the inner lip of the iliac crest and also from the iliolumbar ligament. Iliolumbar ligament is again thickening of the thoracolumbar fascia. The thickening of the thoracolumbar fascia inserted into the transverse process of first to 4 lumbar vertebra and also to the 12th rib. The fibers pass above and gets inserted into the 12th rib and also to the transverse process of the first or upper 4 lumbar vertebra. It actually flexes the spine laterally, unilateral in action. It will flex your trunk laterally this side of this muscle acts, it will bend your trunk laterally on the respective sides. It helps to fix the last rib and thereby it is an accessory respiratory muscle. This is actually covered by the anterior layer of thoracolumbar fascia. Nerve supply is by 12th thoracic and first 4 lumbar nerves. Next, we will discuss about the thoracolumbar fascia. The thoracolumbar fascia is actually present in or disposed in the form of 3 layers: anterior, middle and posterior layers. The anterior layer covers the quadratus lumborum muscle. Anterior layer of thoracolumbar fascia covers the quadratus lumborum muscle. Above thickens to form the lateral arcuate ligament. Below thickens to form the iliolumbar ligament. Medially merges with the psoas fascia. Laterally, it actually fuses with the middle layer of the thoracolumbar fascia and then continues with the fascia transversalis. This is a transverse abdominis muscle. So the fascia covering this will be the fascia transversalis. Okay, that is the anterior layer which I told you. Medially merges with the psoas fascia. Above thickens to form the lateral arcuate ligament, which extends from the T12 vertebra, which extends from the transverse process of L1 to the 12th rib, lateral arcuate ligament, and below it thickens to form the iliolumbar ligament. So blends laterally with the middle layer. I told you middle layer. This is the middle layer of the thoracolumbar fascia. Middle layer of thoracolumbar fascia present behind the quadratus lumborum, but in front of erector spinae group of muscles. So erector spinae group of muscles, they are multi-feeders, rotators, intertransverses, so like that. They help to keep our spine erect. Longissimus muscles are the longissimus thoracis. So middle layer is between the erector spinae and the quadratus lumborum. So that what happens is again laterally it blends with the anterior layer. Below it merges with the iliolumbar ligament. Okay. Above it thickens to form another ligament which is called as the lumbocostal ligament, which is attached to the 12th rib. That is about the middle layer of thoracolumbar fascia. Then what you see here is the posterior layer of thoracolumbar fascia. Okay. So lumbocostal ligament we have seen attaching to the 12th rib. Is the middle layer thickening. This is actually the posterior layer which is present behind the erector spinae group of muscles but anterior to latissimus dorsi muscle. Posterior surface of erector spinae is covered by the posterior layer of thoracolumbar fascia. So attaches to the spine and supraspinous ligaments. Medially it attaches to the spine of the lumbar vertebrae and the supraspinous ligament. Laterally merges with the middle layer that is above the thoracolumbar fascia. Now again we will see a brief description about the lumbar plexus. The lumbar plexus is actually formed by the anterior primary rami of L2, L3 and L4. Mainly it is formed by L2, L3 and L4. The L4 and it is formed with the substance of the psoas major. Now the L4 divides into a large upper branch and a small lower branch. The small lower branch of L4 joins with L5, so forming the lumbosacral trunk. Okay, the small lower branch joins with L5 to form the lumbosacral trunk. That is why the L4 is actually called as nervi forcalis, because it contributes both for the lumbar plexus as well as the lumbosacral trunk. If instead of L4, L5 becomes nervi forcalis, then it is called as post-fixed plexus. If L3 becomes nervi forcalis, then it is actually called as prefixed plexus. So mainly contributed by L2, L3 and L4. Then contribution from the L1 also takes place. Now how actually they take place and forming the branches is L1 joins with a twig from the T12. Okay, L1 actually joins with a twig from the T12 and divides into a large upper branch and a small lower branch. The large upper branch gives rise to iliohypogastric nerve and ilioinguinal nerve. Okay, so the large upper branch, it is a combination of contribution from the L1 and L2. So L1 joins with T12 and divides into large upper branch and small lower branch. The small lower branch joins with the branch from the L2 to give rise to the genitofemoral nerve. The genitofemoral nerve again divides into the genital branch and the femoral branch. Okay. So iliohypogastric, ilioinguinal and then genitofemoral nerve. L2, L3, L4 they divide into ventral branches and dorsal branches. Ventral branches are this one and these are the dorsal branches. L2 and L3 dorsal branch gives rise to lateral femoral cutaneous nerve of the thigh. Dorsal branch of L2, L3 gives rise to lateral femoral cutaneous nerve or lateral cutaneous nerve of the thigh. And dorsal branch of L2, L3, L4 gives rise to femoral nerve. Femoral nerve. Dorsal divisions. Ventral division of L2, L3, L4 gives rise to obturator nerve. Okay. So ventral division of L2, L3, L4 gives rise to obturator nerve. Dorsal division of L2, L3, L4 gives rise to femoral nerve. Dorsal division of L2, L3 gives rise to lateral cutaneous nerve of the thigh. Apart from that, the other branches is which we told, I explained, is the iliohypogastric, ilioinguinal and then the genitofemoral nerve. If at all accessory obturator nerve is present, it will be from ventral branch of L3, L4. This is actually the accessory obturator nerve, not always present. We will pass on to next lumbosacral triangle of Marcelli. So here you see a small triangle which is between medially the L5 vertebra and laterally by the medial border of psoas major. And the base is actually formed by the ala of the sacrum. Okay. So medially by the L5 vertebra, laterally by the medial border of psoas major, and apex is the meeting point of medial and lateral border, and base is actually formed by the ala of sacrum. So that is the lumbosacral triangle of Marcelli. The floor of the triangle is mainly formed by the transverse process of L5 and iliolumbar ligament. So mainly it is formed by the transverse process of L5 and the iliolumbar ligament, which is the thickening of the thoracolumbar fascia that forms the floor of the triangle. Now, numerous structures cross this triangle and they are actually arranged in a deeper plane, intermediate plane and superficial plane. So, along this iliolumbar, the lumbosacral triangle of Marcelli, we see arranged in a deeper plane, intermediate plane and then superficial plane. Deeper plane, you remember the nerves. Sympathetic chain more medially. Then you have lumbosacral trunk, and then you have the iliolumbar artery and obturator nerve. Okay. So this is actually your lumbosacral trunk, sympathetic chain, then the obturator nerve. Mainly you remember these nerves in a more deeper plane. In the intermediate plane, mainly you have the common iliac vessels, that is the bifurcation of common iliac artery into external and internal iliac, formation of common iliac vein by the union of external and internal iliac vein. This is actually present at the intermediate level as a content of lumbosacral triangle. Then superficially, what you see crossing the main structure is the ureter. Then you have the ovarian vessels. Okay, and then inferior mesenteric vessels, they also cross the pelvic brim and to supply the lower part of the sigmoid colon, rectum and all those things. Okay, so superficial plane you have the ureter, ovarian vessels and inferior mesenteric vessels and branches from the hypogastric plexus. So deep plane, you remember the nerves, mainly sympathetic chain, lumbosacral trunk, intermediate common iliac, artery and vein. More superficial, you remember the ureter. These are the important structures. That is about the lumbosacral triangle of Marcelli. Next, we will pass on to the diaphragm. It is also called as the thoraco-abdominal diaphragm because there are various diaphragms in our body. We have pelvic diaphragm, we have urogenital diaphragm, we have oral diaphragm. Okay, so this main principal largest diaphragm in our body is the thoraco-abdominal diaphragm, musculo-tendinous structure which divides your thoracic cavity from the abdominal cavity, and it is a mobile partition or septum. It moves with respiration. Okay, so it moves with respiration, so it is a mobile septum. The center point is tendinous or central tendon of the diaphragm, whereas the periphery is muscular. So the muscle fibers are actually circumferential in nature. They arise from the periphery. All the fibers, they converge to the central part. It is divided into right and left dome of the diaphragm. So you have a right dome of the diaphragm, you have the left dome of the diaphragm. The right dome is at a higher level, the convexity is at a higher level because of the presence of liver. And the summit or the highest point of each dome is actually called as the cupola of the diaphragm. And the center part is actually depressed. The pericardium with the heart is lodged in the central depressed part of the diaphragm. So on thoracic surface, if you look on the upper surface, it is convex. Two dome-like structures you see. This is actually the right dome, which is at a higher level as compared to the left dome. The summit of the dome is actually called as the cupola of the diaphragm. The central part is not dome shaped or convex, it is depressed, the central tendon part, and it is very much intimately related to the pericardium because the central part and the fibrous pericardium has a common source of development. So that is the cupula, that is the highest point of the dome of the diaphragm. Now we are looking at the diaphragm from below. From below it is actually concave or hollow in nature. You will not be able to appreciate the right or left domes or the central depressed part. So the diaphragm from below, if you look, you can see the muscle fibers of the diaphragm, their origin and the major openings you are able to see. The origin of the diaphragm is actually fleshy muscular fibers which arises from three sources. So you have from the zippy sternum, sternal fibers. Then from the ribs and the costal cartilages, lower 5 ribs and costal cartilages, they arise. So they are actually called as costal fibers. The origin is costal in nature. Then posteriorly they arise from the lumbar vertebra. So that is why they are called as the vertebral fibers. So origin is from sternal, costal and then vertebral. Sternal, just a pair of two fleshy fibers from the posterior surface of the zippy sternum. Costal fibers from the lower 5 ribs and intervening costal cartilages. So, inner surface of the ribs and costal cartilages, what happens is these costal fibers, they arise and all the fibers pass medially towards the central tendon. Vertebral fibers arises as the right and the left crus of the diaphragm. Pleura is crura, so you sometimes call it as crural fibers, right and left crus of the diaphragm. And more laterally, it also takes origin from the medial and the lateral arcuate ligaments. We know what is medial and lateral arcuate ligament. Medial arcuate ligament is the thickening of psoas fascia. You are able to see the psoas major muscle. Lateral arcuate ligament is the thickening of anterior layer of thoracolumbar fascia. It is the quadratus lumborum muscle which you are seeing here. So right crus, vertebral right crus arises from the body of L1, L2 and L3, three lumbar vertebra, which means it arises more at a lower level from three lumbar vertebra because the right crus has to displace on the right side a very large organ, that is the liver. So the right crus is longer and more muscular and also gives attachment to suspensory muscle of duodenum. The left crus arises only from the first and second lumbar vertebra and it also gives attachment to the gastrophrenic ligament. So the left crus only from the first and second lumbar, body of first and second lumbar vertebra. Both the crus or the crura, you can tell, right crus and the left crus are actually connected in the midline by the median arcuate ligament. This is medial arcuate ligament, this is median arcuate ligament. Okay. Not only that, we are able to see the right crus also splits to enclose an opening which is the esophageal opening. So median arcuate ligament connects the two crura. Medial arcuate ligament extension is from the body of L1 to the transverse process from which the fibers of diaphragm arise. Then from the transverse process of L1 to the 12th rib is the lateral arcuate ligament. From that also the fibers of the diaphragm arise. So they are all posterior fibers. Anteriorly to fascia slips from the xiphoid process. Then costal fibers from the lower 6 ribs, inner surface of lower 6 ribs and the intervening costal cartilages. Then from the right crus and the left crus from the vertebral bodies and also from the medial and lateral arcuate ligament. The origin of the diaphragm. Now, the insertion, all these fibers, they converge to the central tendon of the diaphragm. The central tendon of the diaphragm is actually trifoliate leaf-like, that Mercedes-Benz symbol. So it has got a central leaflet, then it has got a right and a left leaflet. central, right and left leaflet. The three leaflets, they decussate. Decussation of the fibers of the central tendon takes place to the left of vena cava opening. Okay, so it has got a right and left and a median or central leaflet. They actually decussate the fibers to the left of the vena cava opening. Point of decussation of these three leaflets takes place there. So the sternal fibers are very shortest, and which are coming from the 7th and 8th rib. Costal fibers are the longest. They have to travel a very long distance. Okay. And posteriorly they are crural fibers, which is coming from the right and left cross of the diaphragm. So we have seen about the origin and insertion of the diaphragm. Now we will pass on to the next important aspect of this lecture, that is the openings in the diaphragm. Major openings first. Vena cava opening is actually tendinous, situated within the central tendon at the junction of the anterior and the right leaflet. The vertebral level is T8 at the level of 8th thoracic vertebra. Central tendon, junction of the central and right leaflet, we have the vena cava opening. It transmits the inferior vena cava and the right phrenic nerve. Inferior vena cava and the right phrenic nerve. Now, if the diaphragm contracts during inspiration, naturally what happens is this part dilates. The vena cava opening dilates. So there is an increased blood flow into the right atrium. Okay. The opening dilates on contraction of the diaphragm. The next opening, major opening, is the esophageal opening, present at the level of T10, 10th thoracic vertebra. It is actually between the splitting of the fibers of the right crus, within the fibers of the right crus. When this is a tendinous opening, this is a muscular opening. It transmits the esophagus, it transmits the right and left vagal trunks and the esophageal branches of left gastric artery. Esophageal branches of left gastric artery. These are the structures which passes through the esophageal opening. When the diaphragm contracts, this part actually constricts, it closes. So it closes the esophagus, so food cannot enter. So we cannot breathe and at the same time swallow, or deglutition cannot take place. When the vena cava opening dilates, this esophageal opening constricts. Okay. That is about the next opening, the esophageal opening. The third major opening is the aortic opening, which is situated at the level of T12 vertebra. It is a osteoaponeurotic opening. Speaking strictly, it is not at all an opening, it is a gap between the T12 vertebra and the posterior part of the diaphragm. That is the median arcuate ligament. So in front it is bounded by median arcuate ligament. Behind it is bounded by the 12th thoracic vertebra. Okay. And each side by the right and left crus of the diaphragm. So what is transmitted mainly is the thoracic, descending thoracic aorta continues as the abdominal aorta. Apart from that, it also transmits azygos vein if the azygos vein arises as a lumboazygos. Now, when the diaphragm contracts, no change takes place in this aortic opening. It does not dilate or it does not relax. Because I told you that strictly speaking, it is not at all a opening within the diaphragm. It is a gap between the T12 vertebra and the diaphragm itself. So that is about the major openings of the diaphragm. Now we will see so many minor openings. Mainly between the sternal fibers, you have a space which is called as the space of Larry. Superior epigastric vessels pass through this. and if the space is enlarged, it is actually called as foramen of Morgagni. If the space of Lary is enlarged, it is actually called as foramen of Morgagni. Space of Lary transmits your superior epigastric artery, one of the terminal branches of internal thoracic artery. The next, intercostal nerves between the costal fibers, origin of the costal fibers between the ribs and the costal cartilage. Intercostal nerve, they actually pierce and then they supply the diaphragm. The peripheral part of the diaphragm is mainly supplied by the lower 5 intercostal nerves, and vessels also pass along with the nerves. Between the 7th and 8th costal cartilage, you have the musculophrenic vessels. The musculophrenic vessels, they pierce between the 7th and 8th costal cartilage, and mainly they supply the undersurface of the diaphragm. Behind the lateral arcuate ligament, subcostal vessels and nerves. Behind the medial arcuate ligament, sympathetic trunk or sympathetic chain. Behind the medial arcuate ligament. Okay. Then, piercing each crus is the splanchnic nerves, greater and lesser splanchnic nerves. Okay. Apart from that, you see the ramification of inferior phrenic artery, first branch of abdominal aorta. Last branch of thoracic aorta is the superior phrenic artery. The first branch of abdominal aorta is the inferior phrenic artery. So, arteries are inferior phrenic artery, musculophrenic artery, pericardiophrenic arteries, they all supply the diaphragm. So, major openings, mainly subcostal vessels and nerves, below the lateral arcuate ligament, sympathetic chain, behind the medial arcuate ligament, greater lesser splanchnic nerves piercing the crus. Through the space of Lary, we have the superior epigastric vessels, and between the costal origin, you have the intercostal vessels and nerves, lower 5 intercostal vessels and nerves, they actually pierce and supply. So, main nerve supply, motor supply to the diaphragm is by the phrenic nerve, root value C3, C4, C5, pierces the diaphragm. As a rule, left phrenic nerve pierces the left toe of the diaphragm and supplies the abdominal surface. Right crus gets nerve supply both from the right as well as the left phrenic nerve. The right crus. Sensory again is by the phrenic nerve, central part, and lateral part is mainly, or the peripheral part is mainly supplied by the intercostal nerves, lower 5 or 6 intercostal nerves. There is also a sympathetic supply which actually prevents the diaphragm getting fatigued. From the celiac plexus, there is a sympathetic supply also to the diaphragm. Okay. So, even though it is a voluntary muscle diaphragm, it is involuntary in action. Blood supply, as I told you, musculophrenic, pericardiophrenic, lower 5 intercostal arteries, and superior and inferior phrenic arteries. Superior and inferior phrenic direct branches from the thoracic aorta and the abdominal aorta. Musculophrenic is again terminal branch of the internal thoracic artery. Pericardiophrenic branches are again branches from the internal thoracic artery. Coming to the actions of the diaphragm, I told you it's a principal inspiratory muscle. When the diaphragm contracts, it moves downwards and thereby increases the vertical diameter of the thorax or the height of the thorax. It increases the height of the thorax. Further you inspire, what happens is once the diaphragm is descended, the ribs elevate and the anterior posterior diameter of the thorax is also increases. During quiet breathing, the diaphragm displaces around 1.5 centimeters, but during full breathing or deep breath, it can actually displace from 5 to 10 centimeters. Now, when the diaphragm descends during inspiration, it increases the intra-abdominal pressure, and naturally it is mainly done during vomiting, micturition or defecation. So it acts on the anterior abdominal wall muscles. So it pushes the diaphragm downward. So contents are actually bulged out to your coils of intestine. So increased intra-abdominal pressure inside the abdomen rises mainly during micturition, voiding of urine, defecation, or mainly during vomiting. That is about the principal action of the diaphragm. Coming to the development of the diaphragm, the central tendon is actually developed from septum transversum, which is mesodermal in origin. So septum transversum gives rise to central tendon of diaphragm, fibrous pericardium, and also gives rise to Kupffer cells of the liver. Posterior part from the esophageal opening to the aortic opening is by the dorsal mesoesophagus, or called the dorsal mesentery, because mesentery suspends the primitive gut tube. In the region of esophagus, it is called as dorsal mesentery. Then peripheral part, this muscular peripheral part is from the lateral plate of somatopleuric mesoderm, and in between there is an opening which is called as the pleuroperitoneal canals. As the diaphragm develops, these canals are closed by pleuroperitoneal membranes. Then the muscles from the lateral plate mesoderm, they migrate over the pleuroperitoneal membrane and complete the diaphragm. So it becomes a complete partition, only allowing certain structures to the openings. Okay. So that is about the development. So mainly remember, from septum transversum, dorsal mesentery of esophagus, lateral plate mesoderm, and the pleuroperitoneal membrane. 4 sources for the development of the diaphragm. Finally, coming to the clinical aspects of the diaphragm, diaphragmatic hernias. So mostly diaphragmatic hernias, you have hiatal hernia. So opening, hiatal hernia, when the opening is enlarged, you have hiatal opening, that is the esophageal opening is enlarged. 2 types, rolling type and sliding type. In rolling type, the gastroesophageal junction slides over and the patient has GERD disease, gastroesophageal reflux disorder or disease. So you have heartburns, acid reflux, all those things. Okay, in sliding type. In rolling type, what happens is through the large opening, the fundus of stomach might herniate through this opening and it might present parallel to the esophagus, paraesophageal in nature. In this case, the patient will complain of nausea, vomiting, and also difficulty in swallowing. So that is about the hiatal hernia. 2 types. One is the rolling type, another one is the sliding type. Bogdalax hernia. Congenital, when the fibers fail to arise from the lateral arcuate ligament, the muscle fibers fail to arise, then you see a large hiatus or opening through which herniation of contents takes place. Mainly kidney or coils of intestine might herniate through this, which is actually called as the Bogdalax hernia. So abdominal viscera might herniate. Most commonly seen on the left side, this Bogdalax hernia. The next is eventration of diaphragm or hemidiaphragm, where the one half of the diaphragm, what happens is they fail to contract properly. The diaphragm is normal. Only thing, some few fibers, they might not arise, they might be replaced by membrane. Or it might be congenital or sometimes acquired if the phrenic nerve is damaged, that half of the phrenic nerve, that side, respective side, then naturally the diaphragm will not contract properly, it might be at a higher level. The most common symptom is gasping or difficulty in breathing or short breaths. That is about the eventration of the diaphragm. Hiccups, spasmic contraction of the diaphragm is actually called as the hiccups. So, spasmodic contraction, referred pain of the diaphragm. Irritation of the diaphragm, naturally any pathology of the diaphragm, phrenic nerve, if it is irritated, the referred pain can be felt over the tip of the shoulder, because the root value of phrenic nerve is C3, C4, C5. The tip of the shoulder is supplied by lateral supraclavicular nerve, which also shares the same value, C3, C4, C5 root value. So, referred pain can be felt over the tip of the shoulder. That is for the referred pain of the diaphragm. So, with this, I have completed the diaphragm. Thank you for your patient listening.